Okay, so next topic here. Do a special individual review of some GI topics for Nukes. So just starting out, this is a slide that I have in one of the pediatric lectures, but I'm just going to bring it back up to review real fast because it's a Nukes correlate. So this is a situation where you're provided with a history of prolonged neonatal jaundice. So anytime you hear that, you need to think about one of two things. So uh, one of them is neonatal hepatitis, and the other one is biliary atresia. Now, a good next question or next step question would be, how do you distinguish between these two? And the answer is going to be a HIDA scan. All right, so you do a HIDA scan, and what you want to be able to see is whether or not tracer will go into the bowel or not. If you can get tracer into the bowel, that means you have a common bile duct, which means you don't have biliary atresia. Instead, you have neonatal hepatitis. If you can't put tracer in the bile, you may have biliary atresia. You'll need to get a biopsy of the liver to exclude absence of the intrahepatic biliary ducts. So just reviewing real fast, here is a red blood cell, which is contained hemoglobin. And after a certain period of time, the red blood cell wears out, gets old, and when they get old, they are collected by macrophages. So a white blood cell comes around here and swallows that one up. Yump. So then your heme is then converted into biliverdin, not Billy Verdon, former pirate. And then that breaks down into bilirubin, so which gets excreted here and then gets stuck to a albumin particle, which then gets transported to the liver. And then within the liver, normally, if you've got bile duct anyway, head down through your common bile duct into your bowel, and you poop it out. Now, HIDA is not bilirubin, but it's almost. And what you do is you attach a tracing agent, technetium being the common one, to it. That way it can be imaged. You're not actually imaging the HIDA, you're imaging the technetium. And that goes through similar process and ends up in the liver, just like bilirubin does. And if you have normal biliary tree, then you're going to excrete it into your small bowel. And then if you don't have a normal biliary tree, then it's going to stay in your liver. May eventually get excreted through the kidney. So back to our case here. We're seeing a little bit of, we're not seeing any tracer in the bowel here. So no tracer in the bowel is going to be biliary atresia versus, tracer in the bowel is going to be hepatitis. So here are a few tips and tricks here. Biliary atresia HIDA scan is different than a normal HIDA scan in that you're not trying to exclude cholecystitis, which is a normal reason to do a HIDA scan. So you're going to do like really prolonged delays. You want to make sure that you can tell the difference between these two things because the difference matters. It's a surgical difference. So you need to charge the liver up, the cytochrome system. And the way that you do that is you give phenobarb, and the dose is a piece of testable trivia, 5 milligrams per kilogram times 5 days, 5 for 5. Don't forget, do not forget, when you memorize these things, man, you got to memorize these units too because they can mess with that and change them as distractors. You need to get delays, like very late delays, like more than 24 hours because you really, really, really want to ramp up your sensitivity and be sure. So biliary atresia, there's actually proliferation of ducts inside, but no extrahepatic biliary ducts. It's important to diagnose it early because you can have a Kasai procedure where there's basically a direct anastomosis of the biliary system to the bowel. If you do that early on, the kid will be okay. If you wait, then they're screwed. Absent gallbladder is sometimes associated. They could show you that on an ultrasound to make you think biliary atresia, and there is an association with polysplenia. So why might you be asked to biopsy the liver in the setting of biliary atresia? Now, this is suspected biliary atresia, I should say. This is something I alluded to before. You may have biliary atresia if you don't put any tracer in the bowel. That would be that would be more common than this very rare syndrome, Alagille syndrome, which has absent intrahepatic biliary ducts instead of proliferation intrahepatic, and it's associated with peripheral pulmonary stenosis. So here's a HIDA scan. This is what they're supposed to look like. On your first frame, you're supposed to see prompt uptake of the tracer within the liver, and then over a period, so these are done every 5 minutes or so, and you start to see the biliary tree, start to see a gallbladder. So seeing the gallbladder excludes cholecystitis, essentially. Cholecystitis is an obstructive process. If you can get tracer in, that means you can get bile out, and that excludes cholecystitis. So the way that these are typically done is you let them ride for about an hour. If you don't see the gallbladder, you got two options. You can either give morphine to speed things up, or you can wait up to 4 hours before you call it positive. So here is I'll say this is the 20-minute picture, something like that. And what I'm trying to show here is, one, the gallbladder is absent, so it's probably positive, although you'd have to wait again for the 4 hours to know for sure. And then there's this area of increased radiotracer uptake. This is a so-called hot rim sign. And the reason this occurs is because of hyperperfusion of the liver adjacent to that inflammation. Remember, cholecystitis is an itis, which means it's an inflammation. And because of that, you get some adjacent hyperemia. All right, so let's do a quick review here. So CCK, why do you give CCK? The reason you give CCK is if the gallbladder is full of bile, maybe you can't get tracer in that, and it could give you a false positive. So in a situation where somebody has been fasting for more than 24 hours, you'll want to give CCK to contract the gallbladder, squirt the bile out, and then allow it to get tracer back in. Morphine, why do you give morphine? I mentioned this earlier. Morphine is given essentially to shorten the exam. You don't have to give morphine, but unless you want to wait 4 hours, most people will give it after an hour. And non-visualization of the gallbladder at 30 minutes is the same as not seeing it at 4 hours. So basically saves you 2.5 hours of time. Phenobarb, I mentioned that this is given to prime those enzymes for your biliary atresia studies. What are the doses? All right, let's do the numbers here. So CCK, 0.02 micrograms per kilogram. Morphine, 0.04 milligrams per kilogram. These are not the same. All right. And then phenobarb is mics per kg per day times 5. All right, so next case here, I'll tell you this is an adult patient, not a biliary atresia exam. It sort of looks like it, no tracer in the bowel at all, 0 tracer. And I'll tell you that there was prompt uptake, but it's just persistent, it's not letting it go. So when you see this is a so-called liver sign. Basically, you have a high-grade biliary duct obstruction. Common thing would be a stone, but don't forget that a cancer could do that too. Basically, you put back pressure right. Back pressure doesn't allow the tracer to be dumped into the duct. So prompt uptake, delayed excretion can be mimicked by 2 classic medications. Probably the one worth knowing is Dilantin. Remember, these things always have 2 names. Here's the other one. And birth control can do it as well. They can give you that picture without having a high-grade biliary obstruction. It somehow fucks with the mechanism, and you can't drop the tracer down in the bile ducts. So next case here, this is another way that you can use a HIDA scan. We're seeing prompt uptake, Gallbladder fossas not showing a gallbladder, is photopenic here. And then we're seeing some tracer go down into the bowel, but then we're seeing some of it showing up here like it's dripping down here. Remember, the only thing that's going to be hot is, tracer. Where's the tracer at? The tracer's in the bile. It means the bile is leaking. So this is a bile leak. Now, another sort of linked question, something you could just think about also is, how could you do this with MRI? Well, you can do it with any kind of biliary agent, so like Eovist to be the classic things. Like you could do Eovist and it'll leak everywhere. Just the same here. You can also do it with like Magnavist and stuff like that. Also, you just have to wait longer. All right, so make sure you look in the right paracolic gutter and pelvis because that's where it's going to drip. They could do a thing where they did a cone in like this on you and then maybe not show you that and say, where do you want to look? Here, you want to look down there. Right lower quadrant. There's also this entity called the reappearing liver, which is where, the tracer is slowly emptying out of the liver into the bile ducts, and then suddenly it looks like the liver is getting more, having more tracer in it, like it's reappeared, and that's because it's tracking around the liver. All right, so next case. Now, what I'm showing you here is a SPECT with a correlation on the CT, and we've got a lesion here that's hot. Now, the first question that you want to ask yourself when you see a case like this, a SPECT case through this slice of the abdomen, through the liver and the spleen, is what kind of scan is it? Because it can be a couple different ones, but I want to focus on the three main ones. And if you can figure out what scan it is, then you can figure out what pathology it is next. So here's a strategy. You've got three basic choices: red blood cell scan, sulfur colloid, or octreotide. All three of which are gonna, give you something in that, they can show them through that cut. So which one is which? This is the strategy that I'm going to recommend, something basic. So if you see tracer in the aorta/IVC, then you want to call it a red blood cell scan. If you see tracer not in the aorta/IVC, then you're going to call it a sulfur colloid scan because the half-life in blood is only about 3 minutes for sulfur colloid. Now for octreotide, I want you to look for the hot kidneys. They will show you hot kidneys. They have to. If you do not see a cut through the kidneys, I want you to assume that that they're not hot. Otherwise, they would show them to you. So once you determine what scan it is, then you can pretty much figure out what the pathology is. So why do we do red blood cell scans? For the liver, hemangioma, sulfur colloid, classically the answer is an FNH, right? Even though third of the time they're hot, third of the time they're cold, third of the time they're ISO. But for the purpose of multiple choice, FNH is hot on sulfur colloid. And then for octreotide, all the different neuroendocrine stuff, so islet cell tumors, carcinoid, pheochromocytoma, etc. So let's do this one. So what kind of a study is it? Take a look here. Tracer in the aorta, right? So we know it's a red blood cell scan. If you know it's a red blood cell scan, then you know that it's hemangioma, right? All right, next case. Following the same line of questioning here, we've got orange versus red. What kind of scan is it? So we're not seeing the aorta, not seeing the IVC. They're not showing me the kidneys. So this is a sulfur colloid. And then this one here showing me that the kidneys, this is a cut probably through this level right here. So showing me the top of the kidneys, and then there's a lesion in the liver. So this is an octreotide scan. And if you wanted to get fancy, so second question, it's obviously going to be an FNH, right? There, and then here on our octreotide scan, if you look close, you can see there's also some tracer here, like where the pancreatic tail would be. So that's an islet cell tumor. All right. So real quick review here. Sulfur colloid. What's an HCC going to look like on sulfur colloid? It's going to be cold, right? What about an abscess? Also cold. What about focal fat? Also cold. So is there another test you can use? So remember, gallium is a non-specific thing for inflammation. Tumors can be hot. Abscess would definitely be hot. And focal fat, remember we talked about this in the lung lecture. Xenon, like on a VQ scan, is fat soluble, so it'll displace into focal fat in the liver. So let's just do a quick review of how the sulfur colloid works. So we've got a sulfur colloid particle, and we're going to tag that with technetium. So, and you remember the technetium is the part we're actually imaging. Sulfur colloid is what we're using to try to mimic physiology here, and we know that that is going to get eaten up by the liver's reticular endothelial system. So that comes in there and swallows that up. And then the size of the particles are sort of variable. You know, they range from on the small end 0.1 to around 1.0 micrometers. And the middle vast majority of these particles are supposedly the right size for the liver to eat up. Now, if they're on the bigger end, it's a little bit harder for the liver to eat them, so the spleen reticular endothelial system tends to gobble up those. And if they're towards the smaller end, then you see the bone marrow reticular endothelial system take those up. And what you end up getting is about 80 to 90% of the liver, 5 to 10% in the spleen, and a small amount left over in the bones. So, help you remember this also. So it requires the physiologic function of the liver, right? You need functioning liver to take that up and eat it. The little Pac-Man have to be working in there. So anything that's like doesn't have functioning liver tissue is going to look like a black hole. So that would be a cancer, classically colon met, right? Cyst, hepatoma, abscess, but anything you can imagine that's not functioning liver tissue is going to be photopenic. And that's why FNHs are hot, because they're like hypertrophied normal liver tissue. Alright, so let's take a look here, and I will tell you this is a sulfur colloid. Anterior, posterior. So what we're seeing here is that the spleen is hotter than the liver. Remember that the liver is supposed to be like 80-20 liver spleen, not the other way around. And we're also seeing bones a lot denser. That doesn't look like some small amount. That almost looks like a bone scan. So if this is normal here, this is what we're looking at, where it's reversed and we're seeing some bones. So this is a so-called colloid shift, and you see that in portal hypertension, you see it in cirrhosis, so decreased liver function, less green Pac-Man, and then, you know, if the liver won't eat it, the spleen and the bone marrow will. Alright, so switching gears slightly, this is a bleeding scan, right? So, and it's positive. We see here, we're seeing tracer, a little bit in the stomach, that's normal, depending on the method that's used. Seeing it in the vessels, normal also. So, why do we do bleeding scans? So what is the purpose of the bleeding scan? The purpose is to localize the bleed. We know they're bleeding. You can smell the GI bleed, right? You are doing it to localize it prior to angio, because you don't want to take them down to angio because they're bleeding, and then it's an intermittent thing and they're not bleeding, and you've stuck them and messed around in there, and so you want to know where it's at, because then you can do like provocative measures and stuff like that in angio also to try to get them to bleed if you know where it's at. Also, how is the sensitivity relative to angio? It's actually more sensitive, so this is a situation where the nuclear medicine test is actually superior to more modern stuff. So you'll see this 0.2 cc's per minute for the GI bleeding scan, relative to between 0.5 and 1.0, depending on what you read, for angio. So what do you need to do? How do you interpret one of these things? The trick is you want to see it show up. It wasn't there to start with, and then it shows up, and then it moves, and it can move forward or backward, retrograde or antigrade, because it's like sloshing around in the bowel. Remember, blood also is an irritant to the bowel, so you get spasms and that kind of stuff too. So increase in time and movement. So what about if it stays still? What if you have it show up and then stay still? Well, then you want to think about things like aneurysms, angiodysplasia if it's on the right, like in the right colon. If it's overlying the area of the penis, it might be blood in the penis. You can get a lateral view to do that. You can have if you want to play practical joke on the tech, you can have them change the position. We need you to change the position of the penis. You can do that. That's sometimes fun, especially if it's a male tech, to force them to manipulate some Gomer's penis. We're trying to save his life here, and we're trying to say emergent penis manipulation. All right, so there's 3 methods for tagging a red blood cell, and the differences are potentially testable, so I'm going to go through them here. So in vivo, in vitro, and in vitro. So we'll start with the in vivo method. So what you do is take a syringe with some stannous ion, and you inject that in, and then that's circulating around in the blood there. And then you take a second syringe with some tech and inject that also. So both of these are getting injected. That's moving around in there too. And what you're hoping for is that inside the patient, the tin will act as a reducing agent on the beta chain of the hemoglobin, and that will allow the technetium to stick to it. So there's a classic drug interaction that messes this up, which is heparin tubing, but also can be seen with recent IV contrast. So this kind of stuff's highly testable. It's shitty. You get lots of free tech. Free tech is bad when you're doing GI bleeding scans because free tech goes where? It goes to the stomach, right? And that's being secreted into the stomach, into the small bowel, and that can confuse you. In general, bleeding scans aren't done for upper GI bleeds anyway because of this reason. Endoscopy is superior. Bleeding scans are done for colonic bleeds most of the time. That's where the real utility is, but anyway, it can still make it more difficult to interpret. So that's the shitty one. Now let's do in vivo, in vitro. So you can imagine that this is sort of a combination, right? So we start out similar, inject the tin, that's circulating around, and then you wait 10 to 15 or 15 to 30 minutes, and you pull some blood back out and into a syringe that has tech, and then you're hoping that will bind, and then you inject it back into the patient. There you go, as a labeled tracer. And that does a little bit better. It's more like 85% bound. And then lastly, this is the in vitro method. So in this situation, you draw blood out of the patient, and then you squirt it into a petri dish that has tech and the stannous ions together, and that should bind, and then you draw it back up and then inject that into the patient. So just comparing them here, 60 to 80% bound for in vivo, 85% for in vivo in vitro, and about 98% for in vitro. All right, so that's it, and that concludes this. That's pretty much it for GI.